Hello, Professor Strong. Hey, Professor.
Hello, 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 and hello. Good morning, everyone.
Good morning.
Very good morning.
Professor, I'm driving home still. Is there a way you can check me in, please?
Sure.
Thank you.
Welcome. All right. I checked you in, Cherry. So you are in. Excuse me. Okay, we're still in few students who are missing. Christian, Mary, last name Ibarra, Abhijit, Vishal, Christy, Mehak, Nabila, Therese, Trina, and Taylor, as well as Rabia. So, a few students.
I'm here, Professor.
Okay. Did you scan that QR code, Rabia?
I'm doing it at the moment.
Okay. So how was the exam today?
It was good.
It was good? Okay. So what difference did you see in the previous exams and after yesterday's session? Was it helpful at all? Yes,
I feel
little
like yesterday's session was really helpful.
Yeah, very helpful.
Okay, perfect.
We were going to ask you, Professor, if we can do the same thing next week as well on Wednesday, because we have class, all of us on Tuesday and Wednesday we're at home.
Okay, I'll definitely look into that aspect.
Thank you.
Okay, you're welcome. Okay, we still have students showing absent. Abhijit, Christy, Therese, Taylor. 4 students. So let's just take another minute or so and then we'll start. Do you guys have any questions, anything else while we're waiting? Okay, who hasn't scanned the QR code, guys? We 34, but 2, 4. So one of you who's here still haven't scanned the QR code. Abhijit, Therese. I'm sorry. Who was that?
I'm scanning right now.
Okay, perfect. Can someone drop a text for the rest of the students? I believe a couple still missing. Therese, Taylor, these are the students who are missing. Excuse me.
Taylor's at a doctor's appointment.
Ooh, I'm sorry, who?
Taylor's at a doctor's appointment.
I'm sorry, I didn't catch the name. Who has the doctor's appointment?
Taylor.
Taylor, okay. Thank you.
And Therese told me she won't be able to make it today.
Okay. Okay, yeah, I got see the message. Okay. Okay.
Professor,
Yes.
I have a doctor's appointment at 1:50. So is it okay if I leave early around like 1:30? I need to get my labs done.
Okay, so are you gonna just get off from the lecture or are you gonna stay on the phone?
I can transfer it to my phone.
Okay.
Okay, yeah, but yeah.
Oh yeah, also Professor, I emailed you yesterday on Canvas. I also have an appointment today. So I have to leave like in an hour.
Okay. Okay. Just send me that Canvas message whenever you're ready to leave. Just send a message and I'll follow up on that. Okay. And let me know if any of you, whoever is leaving early, if you will be able to stay on the phone or not, because everybody might be in a different situation. Alrighty. So for Taylor, is she gonna join at all or no?
Taylor's joining. She's joining. She's joining on
Now?
her phone.
Okay.
She's joining.
Okay, I'll just give a few seconds and then if she joins, then we'll move on. So as we talked previously, guys, after today's lecture, pick up your PowerPoints, download your study guide to work with, and create your study guide. So do not delay this process. The sooner you do, better it is. Okay, looks like Taylor's scanned as well. Perfect. Okay. All right, so once again, very good morning, everyone, and we are ready to start our lecture. Here you go. Okay. So do you guys see my full screen? Yes?
Yes.
All right. So today we'll be going over 3 chapters, okay? As compared to the previous week. So these are a little shorter, I would say, but they are equally important, okay? Because the common conditions, some of them are real common and important, and they ask a lot of questions on them. So we need to still focus the same way, but as far as lengthwise, they might be a little short. Okay, first of all, pituitary drugs. So when we talk about pituitary drugs, we need to first know what is the pituitary gland? Then what kind of problems the patient experience, what kind of conditions we're talking about when we have to look what drugs. We need to know the problem first and then the solution. And then while you're providing the solution in form of therapeutical interventions, the drugs, we need to know how they work, any special or specific concerns or different ways of administration, any unique adverse effect, any potential interactions with any medications they're taking, or maybe because of underlying conditions they have. So all those things we need to look into. And then finally, what are the important things you as a nurse should know? Educate your patient and make a part of your nursing process, or when you develop a nursing care plan with your patient who has these conditions. Okay, first of all, neuroendocrine system. When we talk about the pituitary gland, those glands are the one responsible to release the hormones called pituitary hormones. So first, let's know this whole thing, that what it is. The neuroendocrine system, now it's a complex kind of system which includes the nervous system and the endocrine system. Excuse me. Now, what does it do? What role it plays? It regulates various physiological processes in your body and plays a crucial role maintaining the homeostasis, the body growth, reproduction, metabolism, response to stress, like fight or flight response. So when we talk about the system, now let's go over some important parts of it. For example, hypothalamus, right here. Hypothalamus. Now, hypothalamus is the main controls center, which lies just under, located in the brain. the hypothalamus connects your nervous system to the endocrine system. Okay, nervous system to the endocrine system. So now what it does is it receives the signal from the nervous system, from the brain, right? And responds to that. It responds to that. And what is the response? In what form? It releases the hormone, neurohormones, which regulate the pituitary gland, and then pituitary gland release the hormones, whatever belongs to that particular gland. So it's like a control center. It gets a signal from brain and sends the signals to different glands. Then right under that, the small gland, it's a pea-sized gland called pituitary gland, and that's what we'll be discussing here. So this gland is usually, in general terms, they call it as master gland. Now, why it's called master gland? Because it controls other glands. Okay, this is controlled by hypothalamus and secretes hormone, which influence different endocrine glands, such as your thyroid gland, adrenal gland, reproductive organs, are controlled by that. That's why we call it as a master gland. Then there are other glands, endocrine glands. So when we talk about your thyroid, adrenal, pancreas, gonads, which are your ovaries, testes, so they receive the signal, hormonal signal from the pituitary gland and then release the hormone to regulate a normal physiological process of the body, such as mentioned earlier, metabolism, stress, reproduction, and all that. Now, as we just talked about, that signals are received from the brain and then sent over to the other glands, right? So who's the messenger here? The neurohormones, okay? The neurohormones. Now, the hormones are released by who? Hypothalamus into the bloodstream. So then they influence who? The pituitary gland, the master gland, right? For example, hypothalamus, it secretes CRH, the corticotropin releasing hormone. What does it do? It stimulates the release of ACTH, which is called adrenocorticotropic hormone from the pituitary gland. Okay, now that acts on the adrenal gland to release the cortisol in response to what? Stress, the stress hormone cortisol. And then there is a feedback loop. When there is enough, it sends a signal back like, hey, I have enough, don't send more. When it's less, it sends a signal, I have less, send more. So this is how these glands work. Okay, so as far as pituitary gland, there are two lobes, two parts, okay? Two lobes, anterior and posterior. Anterior and posterior. And in the next slide, I'm going to show you the hormones released by these two different lobes, different pituitaries, okay? And that will be important to know that which hormones are released by anterior pituitary gland and which ones are released by posterior. And it may seem like, oh, I'm going to remember it. It's a very easy trick to remember, and I'll share that with you, okay? Here you go. This slide is important. Make sure you know that. Do you see left and right? Different colors there, right? Different color pattern there. So if you look at the right side, that represents hormone released by the posterior side, posterior lobe. See oxytocin, vasopressin, your antidiuretic hormone, those are the ones which are released by posterior. All others which are on the left-hand side, they're released by anterior pituitary gland. So just remember one side, the right one, which is easy to remember, which has only a couple there. Okay, oxytocin and vasopressin, which is your antidiuretic hormone. And then everything else belongs to the left side, which is anterior. Everybody clear? Okay. Any questions so far? All good? Okay. Now, when we talk about these different hormones, like what they do, why they're important, we know that they control various functions of body. So if there's less production or more production, it's going to create an imbalance. And that's not what we want to do. Now, for example, your anterior pituitary hormone, such as like adrenocorticotropic hormone, this ACTH, right? So it stimulates our adrenal cortex to release cortisol. So what does it help with? Body to respond to stress, maintaining blood pressure, regulate metabolism. That's what a function is. So if there is an imbalance, those are the functions. The body will be impacted. Now, if we talk about TSH, thyroid stimulating hormone. Now, this is related to thyroid gland, right? Thyroid gland. So what does it do? The thyroid stimulating hormones stimulate the thyroid gland to do what? Produce the thyroid hormones. Which ones? T3 and T4. If you ever come across where you need to answer, what are the thyroid hormones? Well, they're T3 and T4. And who's stimulating? TSH, thyroid stimulating hormone. And that is something, the standard lab value to diagnose thyroid disorder, TSH. So if somebody asks you, which lab to test? TSH. Now, is there anything else should be included with it? Yes, T3 and T4. But the first answer is TSH. So please know that. Which lab? In thyroid disorder. Okay. Now, what does the thyroid gland or the thyroid hormones regulate? Your metabolism, energy level, growth. You heard about thyroid disorder, like hypothyroidism and hyperthyroidism? You know how in hypothyroidism, people kind of feel a little lazy, low in energy, they're constipated, hairs are kind of, their hairs are kind of falling off, their nails are brittle, skin is dry, and they're gaining weight. They feel cold all the time. Why? Because their metabolism is so slow. That's why they're gaining weight. On the other hand, hyperthyroidism, they have too much of T3, T4, they will lose weight. They will feel hot. Okay, they may have diarrhea, hot flashes. And another thing to remember, when you are performing the labs, so remember I told you three things in thyroid disorder. First, the lab value I said standard uses TSH, thyroid stimulating hormone. And then the thyroid hormones itself, which are T3 and T4. And T3, T4, they go together. Whatever the direction they go to, either high or low, they both travel together. TSH always goes opposite. If T3, T4 is high, TSH is going to be low. If TSH is high, that means T3, T4 is going to be low. Now, what does it tell you? If one is high, the other one is low. Well, when we talk about thyroid disorder, means problem with T3 and T4. Now, if it's hypothyroidism, low. What is low? Thyroid hormones. And who are those? T3 and T4. So if your patient has hypothyroidism, T3 and T4 is gonna go low. Now, what do you think about the TSH?
It's gonna be high because you said it's the opposite.
Absolutely. Good job. Great. Yes. So hypothyroidism means the thyroid hormones are low, and you need to know they are T3, T4. So if they are low, TSH is going up. Now, on the other hand, what if the patient has hyperthyroidism? Now, T3, T4, would they be low or high?
Low.
Hi.
High. High. Hyperthyroidism. High thyroid hormones, which are T3, T4. Now, how about the TSH?
Low.
That'll be low.
Low. Good job. Now, let me ask again. Everybody clear about this concept, these hormones, the lab to monitor which one goes high when, which one goes low with which condition? Anybody who still does not have complete clarity?
Just to reiterate, you said in thyroid we have to check three things: TSH, T3, and T4, right? Those are the only three.
So these are three values to
Three
monitor.
values.
But if they ask you which
For sure.
lab to diagnose this condition, that is TSH. But in order to monitor this condition and monitor the efficacy of your medication, you monitor three, T3, T4, and TSH, all three. But it's about diagnosing the lab value that is TSH.
Okay, thank you.
You are. Anyone else? If it's still not clear, please let me know.
Can you repeat that one more time?
Absolutely. So, number one, the lab for diagnosing, right? Gold standard, that is TSH, thyroid stimulating hormone. And if your patient has hypothyroidism, TSH is going to be high. And thyroid hormones, which are T3, T4, they're going to go low. Okay? Because TSH is what? It's a messenger. When patients' thyroid hormones are low, T3, T4 low, now messenger TSH is in higher number. It's rushing, telling the gland to produce more T3, T4. He's like more messengers going. It's like you see something happening and you're telling everybody, hey, go tell them this is happening. Hey, can you help? Right? So then it's instead of one person, there's multiple going passing on that message, and multiple messengers, more messengers. That's a TSH. When it's too much of T3, T4, then TSH goes down. They give message, hey, shut down. Don't need more. So TSH will go down. But when they're in crisis, means the TSH, T3, T4 low, they're just going there and bombarding the message like produce more T3, T4. All right, now moving forward. Luteinizing hormone, LH. So the target glands, that's your ovaries in the females and testes in males. The function, it triggers the ovulation in females and stimulate testosterone production in male. Okay. As far as follicle stimulating hormone, FSH, once again, it's the gonads, ovaries and stuff. That's what targeting. So it promotes the development of eggs in the ovaries. And in men, sperm. It also stimulates the production of estrogen in female.
Can you repeat that, please?
Yeah. So FSH promotes the development of eggs in ovaries in female and sperm in the testis, which is related with males, and also production of estrogen in females. Next, like growth hormone. So as the name says, growth hormone, this hormone promotes growth. Okay, promotes growth. Cell production, regeneration, metabolism, such as kind of synthesis and fat breakdown, is that what impacted or influenced by growth hormone. Prolactin, PRL. So that the target gland is the mammary gland, which promotes the production of milk in women who are breastfeeding, lactating women. Okay, prolactin. Okay, now moving to right side, posterior. Zara, you have a question?
I do. For when we were on FSH, you said it promotes egg and sperm, and for H, you said it promotes estrogen in women. Would it promote testosterone in men?
I'm sorry, you said the FSH?
You said it promotes eggs and sperms, and then you said for H, it promotes estrogen for women. Does it promote testosterone in men?
Okay, so in women, the target is ovaries, development of eggs. In men, the target is testis, producing the sperm. Okay, in female, there's another aspect that promoting or increasing, stimulating the production of estrogen. Okay, is that it, or there was something I'm missing?
I got that part, but for men, we understand that the promotion of sperm is there. So is there also a promotion of testosterone the same way that there's promotion of estrogen in women?
Okay, this is not something I would say that mainly responsible for that. Okay.
Okay, thank you.
So what was LH again?
Luteinizing hormone.
Yeah. What was the
So
hormones for those?
in female, stimulating ovulation. Okay, and
Okay.
now in men, as Zara was pointing out, so this is what responsible for testosterone production, LH, luteinizing hormone in males.
So LH is testosterone, FSH is estrogen.
So testosterone, correct.
Okay.
Okay, now moving
Thank
to
you.
the right-hand side, you're welcome, posterior. So here we're talking about two, okay? Antidiuretic hormone, which is vasopressin, okay? So there's only two, vasopressin and oxytocin. So vasopressin, the target is kidneys. What does it do? It regulates water balance in the body by increasing the water reabsorption in the kidneys and also maintaining blood pressure and hydration in the body. Okay. Now, as far as vasopressin, the oxytocin. So oxytocin, now the target here is the uterus and mammary gland. What does it do? It stimulates the uterine contractions during childbirth, during the labor. Okay. Second, also promotes milk ejection, production and ejection during the breastfeeding. Also, it plays a crucial role in mother and baby bonding, emotional regulation. It influences that as well. Okay, let's move on. Now let's talk about some problems and solutions, the drugs. For example, these are pituitary drugs which mimic, like produce similar type of effect as the effects produced by naturally produced hormones within the body itself. Okay? For example, if you're giving a growth hormone from outside, it produces the same effect what a growth hormone produced within the body. Okay? Now, in body, when we give medication, right, it could be either body is not producing enough or producing too much. So if it's not producing enough, we give something which lifts up brings it to balance state. If it's making too much, we give something to suppress that production, once again, bringing to balance, right? So the condition would be either hypopituitarism or hyperpituitarism, right? And hypo not making enough, hyper making too much of it, right? So these are some examples. Like posterior, we know that it was antidiuretic hormone, which was vasopressin, and then your oxytocin, and then anterior, these are your casintropin, somatropin, octreotide. We're going to go over that what is important about these drugs, okay? So there are conditions when body does not make enough, and then there are conditions when body is making too much, okay? Excuse me. All right. These are anterior pituitary, casintropin, your somatropin. Number one question is, which patients do we need them? Who are the patients for this? Now, stepping backwards, what is the problem? Well, maybe body is not making enough. When it does not make enough, what is called? Hypo. Hypo what? Whatever the part we are talking about, right? Which part are we talking about? Pituitary gland, right? Hypopituitarism. And it's also called adrenal insufficiency, that the adrenal gland is not making enough. So know that, okay? That's important. Who do we give it to? The patients who has condition adrenal insufficiency. Okay, for example, your casintropin, hydrocortisone. Okay, increases the cortisol production. Where? From adrenal cortex. And that is the reason the condition is called adrenal insufficiency, because adrenal gland is not making enough. It's not making sufficient. Okay. Then the drugs we talk about is casintropin and somatropin. Now, this is growth hormone, a synthesized growth hormone. And as the name says, growth hormone. So it stimulates the growth, Now, what is an important aspect or factor? What you, either the patient or their family, parents, caretaker, you should be educating them to monitor. Any idea? What do you think is really important when somebody's taking this medication?
Bone health?
I'm sorry, what was that?
Is it bone health or like
Look,
or
this is
joints?
given for growth. So you monitor growth, their growth pattern. You ask them to maintain a diary, a journal, and have them bring it on every appointment. Okay.
And this one's for somatropin, neutropin, and serotonin, right? Serostim.
Okay, so excuse me. Particularly when we are talking about growth hormones, that's when we're talking about monitoring growth. And if we talk about the casintropin or hydrocortisone, well, the corticosteroids, they one of the aspects we should be monitoring about is edema, hypertension, as it's highlighted here, because it's a corticosteroids. Corticosteroids retain sodium and water. If they're retaining sodium, water is going to stay with them. Okay. And when they're holding the water, it's going to cause edema. Now, when they're holding the water, means it's more volume in the body. More volume is going to put stress on the heart, raising its pressure. What that called? Hypertension. Okay. Next. So let's once again going over that again. Octreotide, excuse me, or Sendostat. Okay. This thing, it inhibits the growth hormone release. Okay. Remember, we talked about two conditions: either the body is making less or making too much. So here, suppose a condition like acromegaly, the patient is making too much of it. Now you need to suppress it. Okay, you need to suppress it. It's a rare condition. The body's producing too much of the growth hormone, and those patients have, like, sometimes certain body extremities, they are kind of abnormally long. Okay, so then you need to suppress it. This can also be used in certain type of tumors. Okay, it's called like a carcinoid crisis, when because of a carcinoid tumor, it's releasing certain hormones, causing like a life-threatening hypotension. They call carcinoid crisis. It can be used for that. Okay. Here it looks like octreotide. Okay. Also used for treatment of esophageal varices. So it is an increased kind of pressure in esophagus. So the blood supply here, it's like extreme hypertension, and in order to prevent the rupture, this can be used. Okay, what is an important thing to monitor with this drug, octreotide or sendostatin? A real important thing to monitor with this drug is patient's blood glucose level. The reason, it influences patient's blood glucose. Majority of the patients, diabetes, they are type 2, right? Where their blood glucose are high, hyperglycemic type with type 2. And in those patients who are taking octreotide, their blood glucose goes high. But if the patient has type 1, then their blood glucose probably will drop, causing hypoglycemia. So that is the reason that we monitor patients' blood glucose levels more frequently.
So
Okay.
with this kind of drug, are there usually standing orders for glucose testing? Or it's done at
Yes.
home?
So usually you will see that this patient requires this. It's like how if somebody has one condition, you monitor that aspect more often. But with certain drugs, because what they can do to the patient, so these criterias usually are blended in those program, or the softwares, that it pops up there. This is what monitor. If it's not there, well, that's a part of your job as well to monitor. That is why do not give any medication if you don't know about it, right? So if you are giving this medication, you don't know what it's going to do to your patient, what it's for, what you're going to monitor, nothing. So that is the reason you get your drug reference pocket drug reference book out. Look into that. You'll find what's important. But spending just 1 minute will save you a lot of headache. keep your patient safe.
Question.
Yes.
Could you reiterate what it has to do with hypo and hyperglycemia? I got kind of lost there.
Yeah. So it impacts the endocrine gland, okay, which controls blood glucose level. So now, when we talk about diabetic patients, so they only may have two type of conditions, either type 1 or type 2, correct? And type 2 is the most common. And if you have a patient who's type 2, you give them this octreotide, most likely their blood glucose is going to go high. But if the patient is type 1 and you give them the same drug, the blood glucose, higher chance it might drop.
Thank you.
Yeah, but the essence is that we know that it is going to alter the patient's blood glucose level, so we're going to monitor it more frequently. That's what the important aspect is. Okay. All right. Let's see. When administering octreotide standard, do you know what to monitor? What do you think, guys? What, as an RN, would you monitor?
Would it be the blood sugar?
Growth.
There you go. Simple, guys. We just talked about it, right? Simple, simple. Think simple. Don't think complex. Okay? If it was something else, I would tell you that. But remember, I just said the most important thing, monitoring blood glucose level, because we know that's going to happen. Okay? Okay, and okay. Okay, now let's go to some here related to your posterior. Okay, posterior. So as we talked, there are only two, oxytocin, vasopressin, right? Now, these drugs are like antidiuretic hormones. It has to do with hormonal part, because you may come across when they say, so you hear something about diabetes, but here it's not diabetes mellitus, okay? So I'll go over that part as well. So because this is about the antidiuretic hormone, okay? Now, vasopressin. First of all, we need to know, what does it do? How does it work? So as we know, it has to do something with ADH, the antidiuretic hormone. Now, antidiuretic hormone. The hormone, it's against the diuretic hormones. What does that diuretic hormone does? Causes diuresis. What is diuresis? Means excretion of urine, right? Urine output. That's what the diuretic hormone does. So this one is anti. It does not let excessive excretion of urine or fluids. It keeps a balance. Now, if there is an imbalance between that, what's going to happen? If the antidiuretic hormone is less, who is going to keep a balance and not letting too much of water go out, what's going to happen? Too much water going out. So these patients will be dehydrated, correct? You give this medication to keep that balance, that they can reabsorb the water and not losing too much of it. Does it make sense? So it increases the water resorption in the kidneys, right? In the distal tubule and the collecting duct, in the nephrons. And they concentrate the urine and reduce the excretion of water. Now, what is the result? When you increase the reabsorption, decreasing the excretion, what is the result on kidneys? A decreased urine output, correct? So the patient will have a decreased urine output. Is that something make sense or not clear? And what condition mostly happens in? Diabetes insipidus. Okay, remember here, it's diabetes insipidus. It's not diabetes mellitus. It has nothing to do with blood sugar. This is about imbalance of ADH, the antidiuretic hormones. Understood?
Just to clarify, so vasopressin leads to decreased urine output, right?
Yeah. Such
Okay.
as patients with this
Diabetes.
diabetes insipidus who does not have enough ADH, antidiuretic hormone, who could keep a balance and stop excessive loss of water. They were losing water. Now you gave them vasopressin to fill that deficiency they had. Now that will help on to holding more water and excreting less. So these people who were experiencing dehydration because of excessive loss of fluids, right? Now they will not have that excessive loss of fluids and less dehydration. Make sense? Okay. So we need to know, okay, this what condition? Diabetes insipidus. Diabetes insipidus. We're taking this medication. Now, which condition this vasopressin can be used, or which drug to use if patient has a pulseless cardiac arrest? Okay, vasopressin is a highly potent, really strong vasoconstrictor. Okay, highly potent vasoconstrictor. Now, how does it help your patient's condition? Right? How does it work? Well, if we talk about pulseless cardiac arrest, what does that mean? No pulse, right? Pulseless means no pulse. Where a cardiac system. If somebody does not have a pulse, what does that mean? What happened to the heart? It's not beating, right? It's not beating. So, what we do to make it beat? We cause vasoconstriction. Vasoconstriction is gonna increase the pressure. It's gonna now push the blood, supply the blood to the body. Constriction paces up, right? You're putting pressure. It is going to cause what? The pulse, blood pressure will start rising. Vasodilation, remember, causes hypotension, drops blood pressure, right? Constriction increases the pressure. And this drug can increase that. And that's why we can give it to bring that pulse back. Somebody going through a shock, a cardiac arrest, this drug could be utilized for that. So please know that both ways. Which drug can be used for pulseless cardiac arrest? That is vasopressin, right? The reason it's a vasoconstrictor. And if they say which vasoconstrictor can, or if they give you a name, can be used for which condition, the pulseless cardiac arrest or a shock. And that is vasopressin. Everybody clear? Any question?
Yeah, Professor, if you give this to someone for example, just to prevent dehydration and they have a normal pulse, could this lead to like tachycardiac or something like that?
It could, but you may see this. It can be. We have to assess underlying risk factors, conditions, anything else they're taking, which can kind of multiply the risk factor. But yeah, you'll see it if there's no other risk factors associated. Yeah.
Thank you.
Alrighty. What else? What else? What else? Okay, now just going back, when we're talking about vasopressin, right? When there's imbalance of that ADH, antidiuretic hormone. So what was happening? Patient was losing fluids, right? Causing dehydration. Now, if and which condition? Diabetes insipidus. So now, if I ask you, patient with diabetes insipidus who does not have enough ADH, antidiuretic hormone, losing lots of fluid, causing dehydration. What is a expected therapeutic output? Therapeutic output you're expecting if you gave them vasopressin. What are you expecting to happen?
The fluid retention.
Okay. But how would you measure fluid retention? We need to pick up a factor which you can easily compare.
You can measure fluid retention with edema.
Okay. Anything else?
Would it be their blood
Inos.
pressure?
I'm sorry. Can you say that again?
Like blood pressure?
Okay. I guess somebody else was saying something. Who was it? Was it you, Alfred, or
Inos.
somebody?
I said Inos.
Okay. Now, real simple. Remember where I started, what I said. The patient are losing too much of fluids. In which form patient lose fluids? Most common. Urine output, right? Urine. So if they were losing too much, you saw that losing too much in the urine. Now you gave them the drug, right? What would you expect in that urine
Measure
output?
their urine.
Yeah, measure
Less
the urine,
urine.
but what are you expecting?
It's less urine.
Less urine.
Less urine output. There you go. So the therapeutic outcome you're expecting is decreased urine output, and that is going to do what? That's going to cause more fluid retention in the body, so patient will not be dehydrated anymore. But that easiest way to monitor, compare is the urine output. So that's what you should be expecting, a decreased output, urine output. Okay. All right, next. Nursing implication. Now, this part you have to think from a wide angle with a broader approach. That what condition here we are talking about. If it's about growth hormone, then the factors are different. If we're talking about antidiuretic hormones, the factors to monitor or what are important are different. Now let's pick up a couple of examples so that we can go over that. The line on the bottom, right? Parents of children who are receiving growth hormone should keep a journal reflecting the child's growth. Remember I mentioned that previously? So if you're giving somebody whose growth pattern is suppressed, it's not normal, are retarded or slow growth, you're giving them growth hormones. The most important thing to monitor is the child's growth. So you can ask them to maintain a growth journal, bring it on every appointment so you can monitor, how with time, how the patient is responding. Okay, that is very important to know. So if it's about antidiuretic hormone we're talking about, well, for that, if it's for diabetes insipidus, then we're talking about that urine output, right? So based on the condition you are giving for, you include those factors which are important for those patients. Okay. Now, 2 things to monitor, right? Super nurses, double duty guys, okay? What to expect as an expected thing and an unexpected. Therapeutic effect and adverse effect. So as we talked about, if it's a growth hormone, therapeutic effect, like the growth journal, you see that there is a growth pattern, which demonstrate that patient is responding, they are growing, right? You see their height is increasing and all that. Well, that's a therapeutic effect. As far as your diabetes insipidus patients who are dehydrated, you're kind of losing a lot of fluids in the urine. Now the urine output is decreased. Well, that's a therapeutic outcome in those patients, right? And an octreotide, one example here, they say reduce symptoms of carcinoid crisis. These people can have severe diarrhea and stuff and other symptoms with the carcinoid crisis. And if those symptoms are suppressed, means that's also a therapeutic outcome. Okay, now remember we're talking about octreotide, sandostatin, and then there were corticosteroids on the left top. On the top, there are corticosteroids. So whenever you're giving somebody corticosteroid, there are few things to remember, okay, which are important. And no matter what indication, the condition, the disease condition you are giving it for, their properties never change. Number one, anytime you give somebody steroid, and especially if they're diabetic, but even though they're not, but there's a much higher risk with your diabetic patient because they already have high blood glucose. These corticosteroids can increase the blood glucose level. So in them as well, you monitor their blood glucose more often. And if they will be using corticosteroids for a little longer, you may need to adjust the dosage of their diabetic medication to kind of compensate that increase in the blood glucose level. Agree with that? Second, whenever you give them steroids, their blood pressure will also increase. So you should always keep an eye on the blood pressure as well. Okay. Number 3, whenever you're giving them these steroids, it can put your patient at increased risk of mild to moderate and as well as severe risk of GI symptoms, such as it could be just simple GI distress, that's a discomfort, pain and nausea, bloating and all that, to even if they are taking some other drugs along with that, they can even experience GI bleed, such as if they're taking NSAIDs, and you're giving them steroids, you're putting a patient at increased risk of GI bleed. Now, this is the problem we're talking about. Well, if somebody is having pain, you cannot give them NSAID. What can you give? Once again, go easy. Play safe. Super nurses play safe. And then playing safe, what would be the best option to recommend?
Ibuprofen?
What is an ibuprofen? Isn't that NSAID?
Tylenol?
Tylenol, acetaminophen. Okay, acetaminophen, that's what you should recommend. Ibuprofen is an NSAID. Very high risk of GI bleed. With steroids, alcohol, all that, high risk. Cardiac patients, no, that's a big no. All right. Any questions so far, guys? Okay, let's see if you remember. Patient has pulseless cardiac arrest. Which medication does the nurse anticipate administering?
ASO? A?
Okay.
Vasopressin?
Vasopressin?
Yes, you know it. Okay. Trust yourself. Vasopressin. And what is the reason? Which property makes it the choice here?
It increases the blood pressure because you said that it's used in pulseless arrests.
Did I say that? Yes, I did. Sorry, I'm just kidding. Okay. Yeah, you're 100% right. It's a highly potent vasoconstrictor, and vasoconstriction increase that pressure, right? Okay, good job. Okay. Well, we're done with this chapter. Was it easy? The chapter was easy, right? Yeah. It wasn't that lengthy and not too complex, the concept as compared to the previous ones. Some chapters are really kind of give you a hard time. But today's, they're not that hard, but only one I'm looking at is your chapter with diabetes drugs. It's not hard. One is that it has a little more information, and then it has many different type of drugs, which has different type of mechanism of actions and like insulin and all that. And remembering like who's what is what makes it a little tricky. And I'll show you how to manage that situation by creating your 2, 3 tables 2, 3 tables and put them together. That will help you to answer all the questions with that. But if you're not going to do that, it will create a mess in mind. So we need to create those. You guys ready to take a break? Yep, yeah. Okay, 12:04. Let's come back at 12:15. Okay.
Can I ask something while during break?
Yes.
Okay, so you mentioned the 3 things for the corticosteroid. Can you go over that? I got the last 2. It was blood pressure.
Okay. So
Usually,
we're talking about like high blood glucose, right? And high blood pressure. And then there was another one. How was that? Blood pressure, blood glucose. Oh my goodness.
and then the GI problems, right? The third one.
Oh, there you go. Okay, so when you give that medication for a long time, it can put your patient at risk of GI bleed. What you can do is, I mean, not to all. I would say the mild are more common. GI is less common, but that's more severe. So we have to be cautious. So with GI distress, what you can educate the patient to take it with food. So that will reduce the GI distress. Nausea, vomiting, that kind of stuff will suppress. But in order to prevent the risk of GI bleed, there are a few things we can do. And that usually happens with when they're taken either for a long time or they're taken with certain type of drugs, which in combination increase that risk, you know, as compared to if they're taken individually, such as NSAIDs, like ibuprofen, right? So ibuprofen alone itself can put your patient at risk of bleeding. Now we know that NSAID has that ability to do, and we know these steroids has the ability to do. Now it's 1+1, right? So 2 bad guys together is going to hurt more. So that's why we separate them like, hey, we're not going to use you guys together. Replace ibuprofen with acetaminophen Tylenol, which is not going to let that happen. But even with the introduction of acetaminophen, the patient still be at some type of GI bleed risk with the steroid itself, but it's a less risk because we are not giving them the NSAID.
Oh, so there's less of a risk, but it's not permanently gone. Okay, for sure. Thank you.
Yeah. You're welcome. Sabrina, do you have a question as well?
No, I just had to say that I have to go right now. And if you could
You have
also
to go right now?
post the if you could also post the recording.
Yeah. Okay. So, are you leaving completely, Sabrina, or are you gonna switch to your phone?
I'm gonna try to switch to my phone, but it's gonna start lagging.
Okay. Uh, you can try to do that and then text
Mm,
me if you're completely unable to do that, because I don't want you to kind of,
mm.
lose your that attendance as long as you could, if you can hear.
Yeah, I could still be on, but it might like disconnect or it might lag.
That's okay. Just get back in.
Okay.
Okay.
And one more, just a general question.
Mhm.
Uh, since oxytocin usually helps during after pregnancy and all that, is it still important in males today, or?
So, excuse me. There's certain things which are more relevant, are more common issues in certain populations, because they are the one who experience those conditions more commonly. Um, but there might be certain aspects there, but you most of the times, I would say pretty much all the time, you will see more relevant to what the females part that is not in the males.
Okay.
Yeah. Okay, welcome back, everyone. Let's turn the cameras on. All right. Let's move on. Chapter number 2. Okay, this is also an important chapter, as we were talking previously about the thyroid gland. So here we'll talk about the conditions associated with thyroid gland and then the drugs used to treat those conditions. There are important aspects, including which drugs for what, their interactions, contraindications, adverse effect, all those, and what are the important aspects to consider and include when you're taking care of your patients with one of these conditions. So first of all, when we talk about thyroid gland, you can see here, it's a thyroid gland, it's a butterfly shape, okay? And that's the posterior, this is the parathyroid gland, the posterior side, okay? Now the thyroid gland, as I said, it's a small butterfly shaped gland, front of the neck, right here. Okay, now what is the role? It plays critical role in regulating metabolism, growth. It's real important. These hormones kind of affect pretty much all the cells in the body. As far as the lobes, so it has 2 lobes. The right and the left. And then the next important thing for us to know, which I mentioned previously as well in the previous chapter, how to first diagnose it. The lab is TSH to diagnose. What do you monitor? TSH, T3, T4. Okay, is that clear? Now, we know what these do. But have clarity, TSH is not the thyroid hormone. It's a thyroid stimulating hormone. Okay. T3, T4 are the thyroid hormones. So now 2 things can happen, right? Either hypothyroidism or hyperthyroidism. So in hypothyroidism, T3, T4 is low, TSH is high. In hyperthyroidism, T3, T4 is high and TSH is low. Is that clear to everybody? So know the correlation that T3, T4 with the TSH. So 2 goes in the same direction, TSH stays alone and goes the opposite side. Right? Okay. And then there's another hormone which is called calcitonin. Okay, calcitonin. So we know that's T3, T4. That's more related to your metabolism, heart rate, muscle control, development of the brain, all kind of stuff. Then calcitonin, it plays kind of not a big but a small role in a calcium homeostasis, which by lowering the blood calcium level. So it inhibits the breakdown of bone and promotes the incorporation of the calcium into the bone to kind of help reducing the calcium level in the blood. Because when calcium imbalance, what happens is either it's pulling the calcium from the bone into the blood, raising the blood calcium level but making the bones weaker. On the other hand, if it's too much in the blood, it can pull in the bones, reducing the high calcium in the blood. So this plays a role to do so, decreasing the calcium level in the blood. Okay. Okay. I'll show you a short video. Let's see if you can hear the sound. I think I may have clicked on it, but not 100% positive. What happened? There it is. Okay. Did you hear the sound? Ari was there? No?
No.
Wasn't?
No.
Okay. All right. So I guess I have to do it again. Here. There you go. Now I know what it's doing. Did you hear it this time? Yes.
Yeah.
Hey guys, I didn't want it to make you hungry, feel hungry, okay?
Nestled in the tissues of your neck is a small, unassuming organ that wields enormous power over your body. It's called the thyroid. Like the operations manager in a company, its role is to make sure that the cells in your body are working properly. It does that by using hormones to deliver messages to every single one of them. This high-ranking organ is made up of lobules that each contain smaller cells called follicles, which store the hormones the thyroid sends out into your blood. Two of the most important hormones it produces are thyroxine and triiodothyronine, or T3 and T4. As messengers, the hormone's job is to instruct every cell in the body when to consume oxygen and nutrients. That maintains the body's metabolism, the series of reactions our cells perform to provide us with energy. This hormonal notification from the thyroid gets the heart pumping more efficiently and makes our cells break down nutrients faster. When you need more energy, the thyroid helps by sending out hormones to increase metabolism. Ultimately, the thyroid allows our cells to use energy, grow, and reproduce. The thyroid is controlled by the pituitary gland, a hormonal gland deep in the brain that oversees the thyroid's tasks, making sure it knows when to send out its messengers. The pituitary's role is to sense if hormone levels in the blood are too low or too high, in which case it sends out instructions in the form of the thyroid-stimulating hormone. Even in this tightly controlled system, however, management sometimes slips up. Certain diseases, growths in the thyroid, or chemical imbalances in the body can confuse the organ and make it deaf to the pituitary's guiding commands. The first problem this causes is hyperthyroidism, which happens when the organ sends out too many hormones. That means the cells are overloaded with instructions to consume nutrients and oxygen. They become overactive as a result, meaning a person with hyperthyroidism experiences a higher metabolism, signaled by a faster heartbeat, constant hunger, and rapid weight loss. They also feel hot, sweaty, anxious, and find it difficult to sleep. The opposite problem is hypothyroidism, which happens when the thyroid sends out too few hormones, meaning the body's cells don't have as many messengers to guide them. In response, cells grow listless and metabolism slows. People with hypothyroidism see symptoms in weight gain, sluggishness, sensitivity to cold, swollen joints, and feeling low. Luckily, there are medical treatments that can help trigger the thyroid's activities again and bring the body back to a steady metabolic rate. For such a little organ, the thyroid wields an awful lot of power. But a healthy thyroid manages our cells so effectively that it can keep us running smoothly without us even noticing it's there.
Okay, I hope the video gave you just a little bit more visual information about this condition. You guys understand what goes on with this gland and how it impacts? Yeah? Okay. So let's move on now. First of all, as we say, like two conditions, hypo or hyper. Once again, I'm repeating it. In hypothyroidism, the thyroid hormones are low, which are T3 and T4. And the lab which will be higher is TSH. In hyper, at T3 and T4 are high and TSH is low. So once we are clear, now going back to hypothyroidism. So once again, TSH is high, the thyroid hormone, which are T3, T4, they are low. Correct? Okay. So in patients, they are not producing, their thyroid gland is not producing enough T3 and T4, but too much of TSH. Well, we know the lab, TSH. Okay. Next, how do you identify, or how does a patient know, or without doing the labs first, what are the signs and symptoms which can potentially indicate that, oh, maybe this patient experiencing hypothyroidism, right? What are the signs and symptoms? Remember, what does it control? That's where you will see the symptoms, okay? Like your metabolism, energy, all that. So if it is low, the metabolism will be slow, okay? If they have hypothyroidism, means thyroid hormones are low, then metabolism is slow. When your metabolism is slow, means that even they're eating less, but because metabolism is slow, they're holding on to that for longer, they are gaining weight. So hypothyroidism patients will gain weight. Now let's discuss parallel hyperthyroidism. So in hyperthyroidism, they will have more T3, T4, means their metabolism will be faster. With faster metabolism, they're going to consume more energy and they're going to lose weight. Okay, now going back to hypothyroidism, their metabolism is low. They will feel cold. In hyperthyroidism, metabolism rate is higher, they will feel hot. Going back to hypothyroidism, their metabolism is low. They will experience constipation. Going to hyperthyroidism, higher, faster metabolism, they may experience diarrhea. Going to hypothyroidism, they feel low and slow. When you low and slow, you are less active. So these people will have more sedentary lifestyle. Hyperthyroidism, they are highly active. They can't sit. Okay. So hyper patients, they may experience insomnia. And in hypothyroidism, they are more sleepy. Okay. And hypothyroidism, metabolism is slow, they're feeling low and slow, they may experience symptoms of depression. On the other hand, hyperthyroidism, they might be hyperactive. Okay, so we need to know the signs and symptoms, both conditions. Any questions so far? Has everybody understood signs and symptoms associated with both types of conditions? So once again, in hypothyroidism, thyroid gland is not making enough thyroid hormones, which are T3, T4. Now, what is an example? The condition called Hashimoto's thyroiditis. Hashimoto. It's an autoimmune condition where body attacks its own organ, which is the thyroid gland, damages it. and now they're not able to make enough. That is a very common condition. For hyperthyroidism, the condition is called Graves' disease. Graves' disease. Okay, but for hypo, it's Hashimoto's. Once again, signs and symptoms. They have fatigue, they're gaining weight, they're feeling cold, their skin is dry, they're losing hair, they're constipated, feeling depressed, their heart is low, all these things. Now, what is the treatment? Well, treatment lies right next to the problem. The problem is their thyroid gland is not making thyroid hormones. So what is the solution? Give them what they're not making enough, right? Thyroid replacement therapy. That's what we're going to do. Is that right? Okay. Now, once again, these are the signs and symptoms which I told you earlier. Dry hair, okay, losing hair, thyroid gland. In both conditions, actually, hypo and hyper, it could have that swelling enlarged. Slow heartbeat. They're feeling cold all the time. They're depressed, dry skin, fatigue, menstrual disorders, then weight gain, constipation, brittle nail. These are all signs and symptoms of hypothyroidism. Okay. Well, we know the problem now. We know the signs and symptoms. Now the patient is asking, what are you going to do about it, right? What are you going to do about it? So we're going to give them a solution. We're going to give them what they don't make enough. Those are replacement drugs, so thyroid replacement drugs. If somebody asks you, patient diagnosed with hypothyroidism, which means patient is not making enough thyroid hormones, simple words, not making enough T3, T4. And as we just talked about, we're going to give them something, right? Replacement. And they ask, what is the drug of choice? Anybody knows?
Levothyroxine? Or is that for
There you go. Excellent. Anytime or many time, anybody diagnosed with hypothyroidism, they are not making enough T3, T4. So we need to give them replacement drug, which is levothyroxine, brand name Synthroid. You will see majority of the time this drug introduced. Unless they cannot take it, they're allergic to it, they're not responding, then it's a different story. But you will see this drug prescribed. It is very effective and generic is very cheap. Okay. Are there other options? Yes. Why they don't give it? Once again, this drug has enough data which suggests that even though it's cheaper, it's quite effective, very effective. So then comes to insurance asking like, hey, then why you want us to pay several times more than if it has the same efficacy? I don't know. Well, they say if you don't know, we know it, right? So unless there's a reason to justify the use of a more costly drug, I'm gonna give this drug, okay? Unless the data says that that drug is more safe, it is more effective. This is what, but this drug is quite effective, levothyroxine, okay? Now, if we talk about what are the most important things we need to know, this I already told you, which lab, TSH, which hormones are low, T3, T4. So we'll know T3, T4 will be low, TSH will be high in hypothyroidism. So what we're going to give them? Levothyroxine, okay? Excuse me. Next thing is to know what is the usual frequency of this medication? It's taken once a day. Second question, is it any particular time it should be given? Answer is yes. Next question is what time? And answer to that is in the morning. All right. Now the patient comes up with another question. Why in the morning? Why not later? Right? Well, patient can ask any question. So the answer to patient question is number one, you're going to take this drug for this condition. We want to make sure you have a consistent level of drug in your body absorbed in a consistent manner. So when you take it in the morning, okay, first thing in the morning, empty stomach, it gives consistent and better absorption of the drug. Okay. Then they ask, is there anything else? Absolutely yes. I'm going to take you up back when we're talking about the signs and symptoms, right? Now, how does the patient feel with hypothyroidism? Low and slow, right? Low and slow, lazy, sleepy, and kind of depressed, correct? What do you expect when you're giving this drug? We're now addressing those issues, signs and symptoms. So they should get better, right? That's why we're giving this drug. What are we expecting?
High
Improvement
energy.
in symptoms. High in energy, right? High in energy, they're not sleeping anymore, means they're more awake. Well, if you give it in the evening, what's going to happen? Are they going to be able to sleep? They will keep pressing the call light. They're going to say, hello, Zara. Can you send Michelle here if you cannot come? And Michelle like, oh, no, I'm with another patient. They said, hey, Jessica is there. Can you send her? I just want to talk. I can't sleep, right? And Jessica came up and said, yeah, but after 5 minutes, I have to go. But then they said, Alan always say, go with choice B. Can you send him? I just want to talk to him. Is it A could be better for the question, or is it C, or we have to stick with B? Right, Ellen? So they can get you there on the chair or the bench for a long, long time. They just want to talk, they can't go to bed, right? And if it's in one of the facilities and they don't see any other one, you're the only one they can call. It happens all the time. So do not take any risk. Play safe. Give them when they should be taking it, okay? So first thing in the morning, I'll help them. Don't tell them that I'm just trying to prevent that call light, right? Okay. So, excuse me. So in the morning, empty stomach, better absorption, consistent amount of drug in the body, and to prevent insomnia. Okay, everybody's clear? Now, relevant question what we talked about. So what are you expecting once you give these patients this medication? What are you expecting as a therapeutic outcome? Well, they're not depressed anymore, at least less, right? They have more energy. They are, the skin is not dry. The mood is better. They're not kind of gaining weight anymore. So, whatever the symptoms were, are they improving? If yes, that is a therapeutic outcome. Okay, so those are important that the patient reports like, oh yeah, I mean, I feel better. I have more energy. I think I'm able to do more things now. I interact with people. I go and walk and this and that. So yeah, perfect. That's what we are looking for. Now, one thing I want you to kind of understand here is, remember we talked about the T3, T4 is less, the thyroid hormone, right? So this levothyroxine, it's T4. It's T4, but it goes in the body, gets converted into its active form, the T3. Okay, it has to be in the T3 to produce effect. Well, then the next question is, why don't you just give me T3? Right? Well, you give me another T, right? Just give me one T, which is T4, T3. Well, T4, the data suggests, does not absorb well, and majority of that goes waste. And by this method, it's more consistent, better absorption, and better conversion into T3 from T4, directly giving them T3. Okay, that is the reason. Now, the patient say, hey, can you give me both T3, T4? Well, yes, they're drug. Like at the bottom, you see Liotrix, T4, T3, it comes in a combination, but it's more expensive. Majority of insurance may not cover. And there's not a whole lot of data suggesting that it has any kind of, big positive outcome as compared to the levothyroxine. So that's what the insurances look at, like, hey, why? It doesn't make any sense. Cost benefit ratio does not justify that we should pay for that. So that is the reason majority levothyroxine. Okay? But there are other drugs available. Okay, this is just generic. I'm most likely I'm not gonna ask you that, but hey, this is something real good if you know it. Okay, and it's very easy. Excuse me. Levothyroxine dosage is calculated by body weight. Okay, then what is the standard dose? 1.6, microgram. Remember, levothyroxine dose is in micrograms. Okay, 1.6 microgram per kilogram per day. For example, somebody's body weight is 60 kilogram. They're 60 kilogram. 60 multiplied by 1.6, that will give you the total daily dose. Okay, now if patient has less weight or patient is too old, well, they might start more generalized by like 25 microgram a day, and then they slowly increase it. But the standard dose is 1.6 microgram per kilogram per day. And then they stepwise, slowly, they increase it every few weeks. See how patients responding, how well their symptoms are managed. Okay, you have to start low and go slow, because with a slight increase or decrease in dose, your patient may experience severe symptoms. Okay, so be careful about that. And let me show you something to support that. Okay. You see different type of dosage strength and different color of the pills. See that? How many colors? Why? Why so many dosage strength there? The reason, as I said, a slight increase or decrease in dose can make a huge difference in the symptoms. So you have to start low and go up slow. That's why, for example, if it's a 25 milligram, right? Now the patient, if they need 12.5, well, just cut it half, 12.5. If they need 25, give them full. What if they need 37.5, right? You don't want to jump to 50 right away. Your 37.5, well, 1.5, 25 plus half of it, that makes 37.5. Next jump, well, 50. Well, what if they need something in between? Well, then once again, cut half, 1.5, then 75. But from here, the difference goes even more thinner, skinnier here. See, 75 to only 11 increase, 11 micrograms, 75 to 88, 88 to 100, 100 to 112. Because as you go up in the dose, you have to be very careful. Now here you're going close to the usual dose, and patient might be high risk of more severe symptoms with even a minor dose going left or right. And that's why it comes in so many strengths. And just to make it easy, as well as kind of in order to prevent errors in medication administration. It comes in different colors so that even patient can easily identify if something different dose strength is being given to them. Oh, that's not mine. It makes it easy to catch that error. Make sense? Now, do you need to remember which color belongs to what? No, but it's always good to. It's very easy to remember. Just make a mnemonic like how it is on the top left. Orangutans will vomit on you right before they become large, proud giant. If you don't like it, create your own ABCD, whatever you want to do, and look at the first letter like O for orange. You start from 25. Next is W for white, which is 50, and that can help you to memorize the dose related to different color schemes. But you don't need to know. But I just put it if you want to know. Okay, any questions so far? No? Well, let's move on. Now, adverse effect. As I said, whenever it's about adverse effect, unless there are certain drugs which have unique adverse effect, most common will be completely opposite to what you're trying to fix, which are signs and symptoms of that condition you're trying to treat. Now, what were the problems, signs and symptoms here? Patient low, slow, sleepy, depressed, those kind of things, right? So now if they were low, now you gave them the drug. Adverse effect means you fixed it a little more than needed. Well, what's going to happen? Maybe insomnia, right? They were low and slow, heart was beating low, but maybe tachycardia now. It's probably beating faster, right? They were low, slow, depressed, but now the more hyper, maybe anxiety kicking in as well. Well, they were low, slow, gaining weight. If you fix too much, adverse effect could be that they're losing weight now. They were low and slow, sitting, right? Depressed. Well, they were cold, right? They were cold. But here, if you fix it too much now, maybe they're feeling too hot. Is that right? Just think completely opposite to what you're trying to fix. Those are the adverse effect, which tells you what? Maybe the dose is a little higher. What you can do? Decrease the dose. Correct? It's an expected thing. Can happen. And you just lower the dose. And only other thing is a potential interaction that can increase the risk of bleeding if they are given with anticoagulants. Okay, but what I shared previously, all those are very, very important things. Okay, so you monitor their vital signs for like heart rate and all that, how it's going, their weight, and then T3, T4, and TSH, so that you can assess the efficacy of the patient. Now, another very important thing. When it comes to pregnant patient, we always stop, so slow down and think, is it safe to give or not, right? And usually the drugs are like, okay, it's not safe to give during pregnancy. But as far as levothyroxine, this drug is completely safe to give during pregnancy. It's a pregnancy category A, which has no reported adverse effect to mother or the fetus. But one important thing you need to remember, how do we calculate the levothyroxine dose? How do we calculate it? Excuse me.
Body weight.
Body weight. Now, what happens to the body weight during pregnancy?
You gain weight.
Increase. So, what do you think would happen to levothyroxine dose during pregnancy?
Increase.
Increase. So, because the body weight increase during pregnancy, you may need to bump up the levothyroxine dose and then taper it down after the baby's born. Is that clear? Does that make sense? Okay, things has to make sense, right? So we need to connect these things because we know, hey, it's dependent on body weight, man. Somebody has more weight, well, we gotta give more. If it's less, we gotta give more. And during pregnancy, weight goes up, well, we gotta give more. It's that simple. Okay. Moving on. Once again, we know that it's gonna make them more active, more energy. That's why we're gonna give them in the morning to prevent insomnia. Okay. And it's given in the morning, empty stomach. Do not give with anything which can interact or reduce its efficacy. Very common. And that's a generic thing for all drugs that do not give with antacids. Antacids kind of neutralize the effect of other drugs, okay? So you should not ever give with antacid. And also, other common things are if patient is taking like multivitamins, especially like pregnant patients, older patients, very common, right? Because it has calcium, iron, and it can bind to the drug and just flush the drug out without producing therapeutic effect. So patient may experience more symptoms. So those are also the things which you should separate it by few hours. Okay? So please know that. That's important. Calcium, iron, or they say multivitamins, and then antacid. Make sure they're not taken together because it can reduce the efficacy of levothyroxine. Okay, let's do a question real quick here. Patient who's taking thyroid replacement therapy or medication tells the nurse she's starting to experience cold intolerance, depression, constipation, dry skin. The nurse anticipates the manifestation is caused by. Now, are these signs and symptoms of hypothyroidism or hyperthyroidism?
Hypo.
Hypo.
Hypo. What do we give to the patient when it's hypo?
Levothyroxine.
Levothyroxine. So the patient is already taking levothyroxine, right? They say thyroid replacement. But if the patient's still experiencing the hypo symptoms, what does it mean? Hey, we need to increase the dose. Correct? That's the answer. Then maybe the patient is not having adequate amount of the medication. So A is the correct choice, okay? But if the patient experiencing they're feeling hot flashes, diarrhea, anxiety, insomnia, that means the drug is too much, then you decrease the dose. Make sense? Okay. Now let's move on to the second part. When the body or the thyroid gland is making too much of it. Too much of what? The thyroid hormone. Means T3, T4. So now how the lab will look? High T3, T4 and low TSH. Agree? Yes. Okay. Next question. What is an example? Graves' disease. Graves' disease. That's the common one. Okay. Now, if you look at the picture on the right-hand side, you see how the eyes are bulging, right? How the eyes looks like. It's called exothalamus, bulging eyes. Exothalamus. That is a very unique sign. Patient who's experiencing hyperthyroidism. Okay. Now we know the thyroid gland is making too much. What we do? We reduce the production. How? Start with the least. Medication. What are those? We're going to talk about that. What if it still doesn't work? Well, surgery. What do? We take out some part which is making too much. So we leave a little production plant eventually decrease in production. That's what we do. Okay, but not done in the beginning. Okay, you're like, okay, lay down. I'm gonna cut off the part of your thyroid gland, right? Don't do that. Okay, these are the signs and symptoms. We talked about it, right? The patient here, high, metabolism is high. They're losing weight. They're feeling hot. Diarrhea. All those are symptoms associated with hyperthyroidism. I hope everybody's now clear about what are hypo and what are hyperthyroidism signs and symptoms. Okay. Now, how do we treat? As we said, giving them medication. And here comes the names. Might be the radioactive iodine, where you can kind of damage, destroy part of the thyroid gland. Surgery, these are more drastic measures, not done in the beginning, okay? The drugs at the bottom, antithyroid drug. Remember 2 drugs, guys, okay? And I'm going to tell you what is important about that. They ask question on that all the time. There is methimazole and propylthiouracil, also called a PTU. Propylthiouracil and methimazole. These are the 2 drugs commonly used. Okay? Now we know the names. What else is important about them? Well, one of the most important aspects to know if your patient is pregnant. In hypothyroidism, the pregnancy angle, we looked into that, the levothyroxine is completely safe, right? Only thing we need to do is increase the dose of levothyroxine. But here in hyperthyroidism, these are different drugs. There are 2 options available, propylthiouracil and methimazole. Well, what do you look into that? Which one to give in pregnancy? Does it even matter? Does it make a difference? If it does, why? Is it one preferred over another? Is it over the period of full pregnancy or for certain time? That's a very good question. We need to know the answer because it's important. Okay, so please note this down. When a patient is pregnant who has hyperthyroidism, the drug which should be used in the first trimester is PTU, which is propylthiouracil. Okay, propylthiouracil or PTU is the drug of choice which should be used in the first trimester. Well, for how long? Just the first trimester. What to do after? Discontinue. Well, what to do afterwards? Then we pick up methimazole and continue it. Okay, so first trimester, PTU, propylthiouracil. After first trimester, discontinue and start methimazole. Well, why we're doing it? There's a reason.
When
Okay.
is methimazole started?
After the first trimester.
Okay.
If methimazole is given in the beginning, it causes a rare teratogenic effect, and it affects the fetus. Teratogenic effect when they get exposed in the first trimester. But PTU doesn't do that. But why don't we just continue PTU? But PTU have another issue. It can cause a couple of conditions called conal and then esophageal atresia in the fetus. Okay, and also maternal hepatotoxicity, and that is the reason we don't give it during that. And because it's their development of the fetus at that time, the phase when they can impact negatively the most. So that's why we prevent it from taking at that time.
Can you repeat why methimazole is administered in the beginning?
No, methimazole is not used in beginning. Propyl thiouracil is used in the beginning. Okay.
Sorry, I meant because if methimazole is administered in the beginning, what are the effects? Like, what will it do? If it was administered in the beginning?
So,
like, what would it do to the fetus?
Okay, I'll repeat that. Let's just go over a little bit information on this and we'll go back on that. Okay. First is that how does this drug produce its effect? Okay, these drugs like these methimazole, propyl thiouracil, which is PTU. So it inhibits the bond between iodine, and the which kind of makes as the precursor for the T3 and T4, which is your tyrosine, right? So tyrosine and iodine comes a precursor for T3, T4. So when you block that, you are blocking the formation of or synthesis of thyroid hormone. And it also blocks conversion of T4 to T3, T4 to T3. Okay, and T3 is what raises these hormones. That's what the active form is. By blocking it, you're suppressing the hormones. Okay. Now, contraindication is anything which can put your patient at risk or who should not be taking. Here comes it again. Okay. Propyl thiouracil, as I said, should be taken during the first trimester and methimazole for remainder of the pregnancy. Now, example here, scalp abnormalities in fetus when methimazole is used. If you use methimazole, we're using propyl thiouracil, this is what can happen. Okay, does that answer your question? Okay.
Yes, thank you.
All right, now, what else is important? These drugs are strong, okay, has major impact on the body. This drug can suppress the bone marrow, also damage the liver, okay? So what do? We can cause bone marrow suppression, leukopenia, which means it will suppress the WBCs, correct? What happens when WBCs are low? Those are our defense army, right? Patient high risk of infection. Is that right? We need to monitor our patient. How do you know if WBC are less or more or normal? Which lab to monitor? CBC.
CBC.
There you go. Excellent. So that is something important to know because it can cause bone marrow suppression. We need to monitor CBC. Okay. And because it can cause liver toxicity, what are the signs and symptoms of liver toxicity?
Jaundice, yellow eyes, yellow skin.
Yellow. Yellow. Okay. Disease called jaundice. All the secretions, sputum, sweat, tears, urine, everything gets yellow. Okay. Let's move on. One thing is important, the patient understand that this is a chronic condition. If we're talking about hypothyroidism, for example, just pick up one, it's a chronic condition where I would say almost 99% patients, they stay deficient and they need this, replacement therapy, which is levothyroxine. Is it possible that somebody maybe was diagnosed and then things got better? Very rare. Can it happen? Yes. I have seen it. Maybe somebody young, something going on temporarily, which impacted the lab values, or they were probably taking something which was causing that. And when that condition is gone, everything comes normal. But in normal circumstances, it doesn't happen. It's a chronic condition. So you need to educate your patient, make sure they understand it is a lifelong commitment. They have to take the drug every day for the rest of their life. Okay? And never abruptly stop. What's going to happen? They're going to experience more severe symptoms, what we're trying to treat or manage. So that is also very important. And once again, with your antithyroid drugs, like your propylthiouracil and those, you need to monitor CBC because it can cause leukopenia. Okay, now we're going to monitor two things, right? Good and bad, expected therapeutic effects and adverse effects, unwanted. So if we are assessing a patient who has hypothyroidism, we compare their symptoms with the current symptoms that where we at. If it's hyper, we pick up their symptoms, compare with what they are feeling now. And that's how you assess that how well they're responding to the drug. Does it require any adjustment in the dose, maybe increasing, decreasing, or you just continue it? An adverse effect, specific, based on either you give it too much, that can happen, like, tachycardia and stuff when you give too much of levothyroxine, or as we talked about, propylthiouracil can cause leukopenia. And if the patient is saying, oh, you know what, I don't know, like I have a sore throat since last night, and it feels like I'm tired and kind of fever too. What does it indicate? That they're getting sick. Who gets sick? Who get infected? Who get infected? Whose defense is weaker? And whose defense is weaker? WBCs are low. Check their lab. Look at it. That might be a potential indicator that maybe they are experiencing an adverse effect because of PTU. Make sense? Know how to relate the threat. Okay, any questions so far? Many? No? Everybody's good? Okay. Okay, how about this, guys? Let's see. I think we talked about it multiple times. So hopefully I can answer correctly.
D.
D. All agree? D? Yes. And why in the morning?
For better absorption.
It gives energy, so they'll stay up late if it's taken too late.
Prevents insomnia.
And it promotes consistency.
Excellent. Perfecto. All right. Now I'm 100% positive you can educate your patient well, okay? How about that? We didn't talk about it, okay? So, guess.
B.
You said D? Is
No,
that
B.
personal preference or, oh, B, sushi?
Yeah, I always say B, remember? That's why.
That's what you like? Oh, yeah, I know. Maybe you like it as well, right?
Yeah.
Yeah. What else, guys?
Would it be tofu burger?
Is that personal preference? You like tofu, or is it as something which kind of, drives you to choose that?
No, because the other two are like seafood, and the pasta. But I just went with tofu burger. It sounds healthier.
Is it something relevant with this medication, with the seafood?
No shellfish.
Iodine.
Hey, excellent. Iodine. So you do not mix with iodine. The seafood, sushi, that's what seafood, you do not give it to them. And same with the tofu, it's a no, no, and no, and no. So what you left with is pasta with marinara sauce. All right. Sorry, gentlemen, Alan, that we could not come up with sushi, okay? We have to just settle with this pasta with marinara sauce. Okay? All right. Let's go over. Do you know what this looks like? What it is? Don't say it's a question, okay? Other than that, more detail. Have you ever heard about NGN questions? New generation NCLEX questions? Yeah? These are the NGN new generation NCLEX questions, okay? Now, what are the positive aspects and what are the negative aspects of these type of questions? Because they started doing it, right? So there's a certain percentage they're replaced with normal multiple choice with these NGNs, NCLEX. Now, don't feel stressed, okay? Because what I have seen, actually, it's helping the students more to answer correctly rather than impacting negatively, okay? The reason, you have more information data available to come up with the right answer. They share more data with you. It gives you clear, better picture. Now here, let's go over that. Only thing is that it's a lot of data and it consumes a lot of time. That is the negative part. Okay. But as you read, you should know how to extract the information, what you need. Now, 36-year-old female reports extreme fatigue, exhaustion, difficulty waking for work in the morning, trouble concentrating. She has experiencing a 10-pound weight gain over the last 2 weeks. Now, what we just learned during this chapter, what do you think? Are there signs and symptoms of hypo or hyperthyroidism?
Hypo.
Hypo.
Hypo. So now in your mind, you have clarity. The patient is probably struggling with what? Hypothyroidism. Let's keep moving. The client is admitted to an outpatient clinic with enlarged thyroid. There you go. Another confirmation. Puffy face, dry, pale skin. More confirmation. She's wearing a heavy sweater on a warm day. Another confirmation. Remember, hypothyroidism, they feel cold. Correct? She states she has body aches all over, frequent muscle cramping, constipation. Nails are brittle. Her hair is coarse and dry. She reports feeling depressed over the last few weeks. Whole picture tells you one problem, hypothyroidism, right? Everything aligns with hypothyroidism.
I have a question, but
Yeah,
enlarged thyroid gland, wouldn't that be hyper, or that doesn't have anything to do with size?
it can happen with both.
Oh, okay.
It can happen with both. But remember, that's not the only sign and symptom we are considering here. There are like 10 more, right? So now the temperature 96.6, heart rate 53. Now, is that a low or high?
Low.
Low,
No.
right? So this also supports our diagnosis of hypothyroidism, correct? Respiration, okay. Blood pressure is slightly high. Now, maybe the heart is trying to compensate that heart rate, which is slow. Oxygen, fine. Weight gain, they said that they're gaining, right? Now, let's look at the lab, okay? Which were three things we were looking at? TSH, T3, T4, right? So TSH first, it's 20.8, normal is 0.3 to 5. What is it? Is it high or low?
High.
High. Now T4, Supposed to be 4. I'm sorry, it's 4. Supposed to be 5 to 12. It is low. Then does hematocrit, we are worried about it in this? No, hemoglobin 9, it's low, right? It's low. But TSH high, T4 low. The lab confirms diagnosis of hypothyroid. We all clear, right? We're on the same page. We 100% clear that it's hypothyroidism. Agree? Now let's move forward. The nurse is reviewing the client's assessment data, vital signs, lab to prepare outpatient client's plan of care. Complete the diagram by dragging this. Indicate one potential condition. So all of you, what is the condition? What is the diagnosis?
Hypothyroidism.
Hypothyroidism. Okay. 2 actions the nurse would take to address the condition, and 2 parameters the nurse would monitor to assess the client's progress. So now let me show you that. So we all know, right? Condition, hypothyroidism. Okay. Now, what are the 2 actions out of this? Give preoperative teaching for thyroidectomy, means that surgery. Do we perform surgery in hypo or hyperthyroidism?
Hyper.
Hyper. So cross it out, correct? Encourage increased caloric intake. Is that something to related with the calories?
No.
No, right? Cross it out. Provide information on anti-thyroid therapy. Do we give anti-thyroid therapy to hypo or hyper?
Hyper.
Hyper. So cross it out. What are the 2 left? Discuss the importance of thyroid hormone therapy, right? Levothyroxine for hypothyroidism. Number 2, teach ways to prevent skin breakdown because they're going to have dry skin. Okay, so those are the 2 actions to take. Now moving to the most right, parameters to monitor. Bleeding. Is there any risk with this condition that the patient can bleed? No, right? Doesn't belong. So cross it out. Fluid intake and output. Is that some imbalance of fluid? No, there's no fluid imbalance. Lab values. Is there something you need to continuously monitor? Absolutely yes, right? That's where we know that hey, something abnormal, and only time we would know is by monitoring the labs if it's normal or not now. Correct? During the treatment as well. Neurological status. Is something patient showing any neurological symptoms? Anything severe? No. How about vital signs? Always. So the 2 parameters to monitor, the lab values and vital signs. You guys agree with me on that? You on the same page? This is how you extract the information in NGN. Not just, okay, I'm going to read something, I'll think, then I'm going to read what they're asking me, then answer options. It's going to take too much time. Start developing your whole thought process based on what you see there. What is the potential condition? Why I'm coming to this conclusion, either it's because of lab or the signs and symptoms, and what I should be doing. And by the time you reach at the end of the question, you should have think clear in your mind. And once you start reading the answer options, you will know it clearly. Okay, perfecto. Any question, guys? But did you see how in that NGN question, whatever the options, either it's identifying the condition, the diagnosis, or what to monitor, although everything was there, right? You just have to bring it. You just have to grab it. It was there. And that's a positive thing. A lot of students who were struggling from long time to pass the NCLEX, they find it easy to pass with this information. So in the beginning, there was a lot of fuss about it. People were like complaining, oh my goodness, it just wasted your time. It takes so long. It's so stressful. How we're supposed to do. But hey, look, you got to follow the process. We cannot change it. Then once our students start going through it, a majority of them actually saw something positive. It's only the only difference is that you need to change the approach, that you start making that picture in your mind as you read the question. You won't get time to read it back and forth once again. Oh, I'm going to read it again. No, you learn how to develop that while you're reading. Okay. All right. So let's take a break. It's 1:22. We'll be back at 1:32. Okay, welcome back, everyone. Okay, please turn on your cameras. Okay, let's move on, guys. This is a very important topic, a very relevant topic, and it will be more relevant in the years to come. Lots and lots of people are, or their lives are impacted by this. And from what I see, what I understand, that in the years to come, it's going to get worse, not better. You will see very high number of patients with diabetes and other complications because of uncontrolled diabetes. People are not understanding, not able to see and think clearly that what's happening. We eat based on how it looks, not then how it impacts. What we put in, that's what impacts, that's what makes, that's what determines how our body will be in the coming days. Without realizing the consequences, people just eat based on what they know or what they've been told, what they've been conditioned about, or they just like it because either taste or flavor or how it looks. Not the right approach. Not the right approach. A lot of processed food these days. A lot of things which should not be in the food. They are. In our country here, we have one of the worst food quality. Okay. Even if we talk about fast food in other countries, like if you go to Europe, okay, you pick up the same menu item, what you eat here in Europe, it's day and night difference. The tons of those chemicals which are allowed here, either in the production, at the grassroots level in the farms, or when they are processing it at the next level. It's decades ago, they were banned in Europe. They're dangerous. But the corporate industry is way big here, and just keep going on without focusing on or realizing that how badly it's impacting the whole population here. Now let's go on. All right, so we'll talk about diabetes, types of diabetes, different type of drugs used for diabetes, and then any interactions, contraindication, how to manage adverse effects, and anything else which is crucial when you're taking care of a patient who has this disease. Now, when we talk about diabetes, so we're here in this chapter, we are not talking about diabetes insipidus, what we talked in the previous chapter. We're talking about diabetes mellitus, right? Where blood glucose is the concern here. So the blood glucose goes high, which we simply call the sugar, right? So blood glucose high. And the reason behind that is that insulin, that's what the body is deficient in. Well, then what is the connection of insulin? We're talking about sugar here, blood sugar. Where the insulin come from? Well, insulin is what responsible, who opens up the channels. It's like you have a door and you have a lock on it. Okay, insulin is the key to open the door. How does it align with blood sugar? Well, until the door is closed, blood sugar means the sugar in the blood, right, cannot enter through the door. While door takes them where? In the cell. So in that scenario, when the door is closed, the glucose keep flowing in the blood vessels. That's when you see high blood glucose, right? The glucose is high in the blood because it cannot move away from blood to the cells and store as a form of energy. That's like a fuel. We need fuel, right? So they're deficient in insulin. And there are two types of diabetes, type 1 and type 2. Type 2 is the most common, usually in the higher age group, and type 1 is more younger in kids. That's where the type 1 we see the most, okay, which is less common. Type 1, you always have to give them insulin. They just cannot make any. In type 2, either they're not making or they're not making enough. So you need to address in a different way. Okay. Let me see how long is this video. If it's too long, then I won't be able to play. But if it's short, then I'll play.
Think of a poem about your identity. Funding our school is a big challenge. I am a passionate and purposeful educator. I've had to do after-school tutoring and
Understanding type 2 diabetes. Type 2 diabetes is a metabolic disorder that causes sugar, in the form of glucose, to accumulate in the blood rather than being used as fuel by the cells in our body. When we eat, food is broken down by our digestive system into nutrient molecules that are then absorbed through our digestive tract for use by the body. Foods containing carbohydrates or various sugars are broken down into glucose. Glucose is an important source of fuel for many organs in our body. However, to be able to use the glucose for fuel, the glucose molecule must first enter into the cell. The pancreas produces a hormone called insulin, a chemical messenger essential for the entry of glucose into cells. As the blood glucose levels rise after a meal, insulin is released into the bloodstream and sets processes in motion to trigger the removal of glucose from the blood to enter into the cells. In type 2 diabetes, the cells become resistant to insulin and ignore its message to absorb glucose. This is known as insulin resistance. In addition, in type 2 diabetes, the pancreas is unable to produce the greater amounts of insulin needed to trigger these resistant cells to take in glucose from the bloodstream. The most notable symptom of diabetes is frequent urination and excessive thirst. Other symptoms include weakness, drowsiness, and blurred vision. These are caused by chemical imbalances in the blood related to high levels of blood glucose. About 1 in 4 people with type 2 diabetes are unaware that they have the disease. It is important to catch diabetes early. Over time, high blood glucose damages the blood vessels, which can damage the organs that these vessels supply, leading to a variety of health complications. Damage to the small or micro blood vessels can cause vision problems, including loss of sight, nerve damage, and kidney disease. Damage to larger or macro blood vessels can lead to cardiovascular complications such as heart disease, stroke, and poor blood circulation. Overweight and inactivity are major causes of diabetes. A family history of diabetes significantly increases your risk of developing the disease. Certain ethnic populations are also at increased risk of developing type 2 diabetes. Finally, some medications may increase your diabetes.
Do have some more videos, but I believe that probably lengthy. Let me see if I can pay maybe one or so. But I want you to watch these videos and arrange, organize your drugs. Okay, that is important. Let me see if how big this one is. It's quite big, but let's play a little bit.
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes that your cells need glucose as a source of energy. So not letting the glucose enter means that the cells starve for energy, despite having glucose right on their doorstep. In general, the body controls how much glucose is in the blood relative to how much gets into the cells with two hormones, insulin and glucagon. Insulin is used to reduce blood glucose levels, and glucagon is used to increase blood glucose levels. Both of these hormones are produced by clusters of cells in the pancreas called islets of Langerhans.
Let's learn about C3 glomerulopathy, a rare disease that affects how well your kidneys work.
Insulin is secreted by beta cells in the center of these islets, and glucagon is secreted by alpha cells in the periphery of the islets. Insulin reduces the amount of glucose in the blood by binding to insulin receptors embedded in the cell membrane of various insulin-responsive tissues, like muscle cells and adipose tissue. When activated, the insulin receptors cause vesicles containing glucose transporter that are inside the cell to fuse with the cell membrane.
We did cover that in the previous.
Diabetes have type 1, and the remaining where a person's own T cells attack the pancreas. These are part of our own body's cells. All sorts of antigens. What this happens is that in type 1 diabetes, there's a type 4 hypersensitivity response, and that some of these that causes a loss of self. Losing beta cells means less HLA system. Cells maintaining self-tolerance. In diabetes mellitus type 1, destruction of beta cells usually starts early in life, but sometimes up to 90% of the beta cells are destroyed before symptoms crop up. 4 clinical symptoms of uncontrolled diabetes that all sound similar are polyphagia, glycosuria, polyuria, and polydipsia. Let's go through them one by one. Even though there's a lot of glucose in the blood, it cannot get into the cells, which leaves cells starved for energy. So in response, adipose tissue starts breaking down fat, called lipolysis, and muscle tissue starts breaking down proteins, both of which result in weight loss for someone with uncontrolled diabetes. This catabolic state leaves people feeling hungry, also known as polyphagia. Phagia means eating, and poly means a lot. Now, with high glucose levels, that means that when blood gets filtered through the kidneys, some of it starts to spill into the urine, called glycosuria. Glycose refers to glucose, and urea, the urine. Since glucose is osmotically active, water tends to follow it, resulting in an increase in urination, or polyuria. Poly again refers to a lot, and urea again refers to urine. Finally, because there's so much urination, people with uncontrolled diabetes become dehydrated and thirsty, or polydipsia. Poly means a lot, and dipsia means thirst.
Nothing this good comes this easy.
Except Factor.
Fresh, never frozen meals ready in 2 minutes.
We all struggle. We just don't like to admit it. Sometimes you'll need help. Sometimes you'll.
Even though people with diabetes are not able to produce their own insulin, they can still respond to insulin. So treatment involves lifelong insulin therapy to regulate their blood glucose levels and basically enable their cells to use glucose. One really serious complication with type 1 diabetes is called diabetic ketoacidosis, or DKA. To understand it, let's go back to the process of lipolysis, where fat is broken down into free fatty acids. After that happens, the liver turns the fatty acids into ketone bodies. like acetoacetic acid and beta-hydroxybutyric acid. Acetoacetic acid is a keto acid because it has a ketone group and a carboxylic acid group. Beta-hydroxybutyric acid, on the other hand, even though it's still one of the ketone bodies, isn't technically a keto acid, since its ketone group has been reduced to a hydroxyl group. These ketone bodies are important because they can be used by cells for energy, but they also increase the acidity of the blood, which is why it's called ketoacidosis. And the blood becoming really acidic can have major effects throughout the body. Individuals can develop Kussmaul respiration, which is a deep and labored breathing as the body tries to move carbon dioxide out of the blood, in an effort to reduce its acidity. Cells also have a transporter that exchanges hydrogen ions, or protons, for potassium. When the blood gets acidic, it's by definition loaded with protons that get sent into cells while potassium gets sent into the fluid outside cells. Another thing to keep in mind is that in addition to helping glucose enter cells, insulin stimulates the sodium-potassium ATPases, which help potassium get into the cells. And so without insulin, more potassium stays in the fluid outside cells. Both of these mechanisms lead to increased potassium in the fluid outside cells, which quickly makes it into the blood and causes hyperkalemia. The potassium is then excreted. So over time, even though the blood potassium levels remain high, overall stores of potassium in the body, which include potassium inside cells, starts to run low. Individuals will also have a high anion gap, which reflects a large difference in the unmeasured negative and positive ions and in parallel a need for alternative energy, hydration. Insulin, which helps lower blood. Essentially, the body's providing the normal amount of insulin, which is where the body makes insulin, but the tissues don't respond as well to it. The exact reason why cells don't respond isn't fully understood. Essentially, the body's providing the normal amount of insulin, but the cells don't move their glucose transporters to their membrane in response, which remember is needed for the glucose to get into the cells. These cells therefore have insulin resistance. Some risk factors for insulin resistance are obesity, lack of exercise, and hypertension, and the exact mechanisms are still being explored. For example, an excess of adipose tissue, or fat, is thought to cause the release of free fatty acids and so-called adipokines, which are signaling molecules that can cause inflammation, which seems related to insulin resistance.
Let's learn about C3 glomerulopathy, a rare disease that affects how well your kidneys work.
However, many people that are obese are not diabetic, so genetic factors probably play a major role as well. We see this when we look at twin studies as well, where having a twin with type 2 diabetes increases the risk of developing type 2 diabetes, completely independently of other environmental risk factors. In type 2 diabetes, since tissues don't respond as well to normal levels of insulin, the body ends up producing more insulin in order to get the same effect and move glucose out of the blood. They do this through beta cell hyperplasia, an increased number of beta cells, and beta cell hypertrophy, where they actually grow in size, all in this attempt to pump out more insulin. This works for a while, and by keeping insulin levels higher than normal, blood glucose levels can be kept normal, called normoglycemia. Now, along with insulin, beta cells also secrete islet amyloid polypeptide, or amylin. So while beta cells are cranking out insulin, they also secrete an increased amount of amylin. Over time, amylin builds up and aggregates in the islets. This beta cell compensation, though, is not sustainable. And over time, those maxed out beta cells get exhausted, and they become dysfunctional, and undergo hypertrophy, and get smaller, as well as hypoplasia and die off. As beta cells are lost and insulin levels decrease, glucose levels in the blood start to increase, and patients develop hyperglycemia, which leads to similar clinical signs that we mentioned before, like polyphagia, glycosuria, polyuria, and polydipsia. But unlike type 1 diabetes, there's generally some circulating insulin in type 2 diabetes from the beta cells that are trying to compensate for the insulin resistance. This means that the insulin-glucagon balance is such that diabetic ketoacidosis does not usually develop. Having said that, a complication called hyperosmolar hyperglycemic state, or HA.
Okay, guys, I guess I'm gonna skip the rest, but you do have access to that. So I want you guys to watch that video, okay? That is extremely helpful. But I hope you kind of have a good understanding of the basics behind this diabetes type 1 and 2. So type 1, as said, it's an autoimmune where immune system attacks its own beta cells in the pancreas who produce insulin, and then they're not able to produce, and then resulting in low insulin level and high blood glucose, and they need insulin. On the other hand, in type 2, when the body becomes resistant to the insulin, or the insulin production goes low and resulting in higher blood glucose. And here, lifestyle modifications are what the starters are, and then adding pharmacological interventions, your oral or injectables, based on the severity. Okay, but lifestyle changes are what the beginning is. So as I said, diabetes mellitus, we know increased blood glucose, we know type 1, type 2. And the common sign and symptom, as in the video as well, it explained polys, okay, polyuria. Poly means a lot, urea means urine, right? So a lot of urine, they urinate a lot, they pee a lot. Then polydipsia, because they're losing fluids, they're thirsty. Polyphagia, there's not enough fuel, they are hungry. Glycosuria means, urea means urine, glycose, so glucose in the urine. Okay. Now, they will experience, most of them, an unexplained quick weight loss, they are tired, and over a period of time, they may complain about blurry vision. And that's why we recommend yearly eye exams, because it can damage their vision over time if it's not controlled or managed well. Then one important aspect first is, how do we or which lab value do we monitor the patient has diabetes? What is the most reliable?
A1C.
Yeah, HbA1c, hemoglobin A1c. So that is very important to know, okay? That gives more consistent values, data, over a period of time, or a period of 3 months or so. So that is one thing which is important. And we all know the reasons behind diabetes, especially type 2, it's more unhealthy lifestyle, what we eat, and all those kind of things. And by working on those aspects can help improve and prevent future complications. Okay, so we just talked about it. The important lab to monitor is hemoglobin A1c. In diabetic patient, the goal is to keep it below 7. Okay, below 7. That's what the goal is. Now, type 1, they always need insulin, and type 2, lifestyle changes first, then oral, alone, or in severe cases, maybe injectable. Okay. Insulins are what is that you're giving from outside, what body's not making or not making enough. And then oral, they have different mechanism of action to reduce the blood glucose. So let's go over that. There are many different type of drugs available. As far as insulin, so it's basically supplementing or substituting what we don't have, but your patient does not have. So it just technically allows the same function which we talked previously, what a normally human body produced insulin does, right? So insulin is your hormone produced by the beta cells, pancreas. So which allows entry of glucose into the cells, is stored as form of energy, future fuel. But if not enough insulin, the gate doesn't open And the sugar, the blood sugar, the glucose cannot enter inside the cell, so it just keeps flowing out, which means in the blood, causing increased level of glucose in the blood. Now, if we talk about insulin, okay, there are different types of insulin. Some acts quickly, some takes longer, some does not last long, some last long. Some it's important to give with food, some does not matter. So let's understand some basic concept, okay? Number one, and I want you to develop your own sheet for this purpose because you will be tested on this, okay? Where you will need to know, okay, all these rapid, regular, intermediate, long, ultra long, and which one are those? If you're given a name, how would you know which one is what? Or if you are given rapid acting, like how do you know that which one are the rapid acting? So you need to know both ways. From the class itself, what they fall under, which ones are there, or if the name is given, you should be able to identify which class they belong to. So first, rapid acting. Now, as the name say, rapid acting, they act rapidly, quickly. Okay, so that is one aspect. They act quickly, but they do not last long. Now, let me ask you again. Why are we using insulin? Because your patient's blood glucose is high, right? Now, if they are going to eat, right, after food, is the glucose going to go high or low?
Hi.
High, right? That is why you need these rapid acting mealtime, right? Need to act quickly at that time, but you don't want it to last longer. You don't need to last longer, okay? Rapid acting. So means in 10, 15 minutes, some places you may see it 5 to 15 minutes, but usually 10, 15 minutes that's what it takes them to work, right? Then you need to know how long does it last or when it peaks. Actually, three things. How quickly it works, when does it peak, how long it lasts. So these three factors should be included in your sheet. Number one, you write down rapid acting. Second number, you write down which one are those. Remember, AGL, okay, what that means. Insulin aspart, insulin glucin, and lispro. And the examples, they end with log, Humalog, Nuvolog. These are your rapid acting insulins. Okay, as we know, they're going to act quickly, 5 to 15 minutes or 10, 15 minutes, but it's not going to last longer. They peak between, I would say, from somewhere from 30 to 90 minutes or hour to two, generally. That's where the most impact they're going to produce. They last only somewhere from 3 to 5 hours or so. So this should be taken right before or right after the meal, just right with the meal technically, because if they don't eat meal, well, it is going to drop their blood glucose dramatically. So these are meal times. Okay. Second one, regular. Okay. They're also called short acting. Regular also. Now, with their names, you will see an R at the end. See, Humulin N, Novolin R. They will have R means regular at the end. Now, they are not rapid acting. They're short acting, okay? They take a little longer. Now, we talked about 15 minutes the rapid acting takes. Now, double it up. So they will take about 30 minutes or so. So 30 to 60 minutes it will take to work, onset. Then the peak will be around 2 to 4 hours or so. And they will last somewhere, 4 to 6 hours, or could be even 8 hours. Okay. Next is your intermediate. intermediate. Now, intermediate, they will have an N at the end. Intermediate, they also called as NPH. NPH, and they end with N. And remember one more important aspect. These are the only insulin which are cloudy. They are not clear. Okay? If they are clear, they are bad. And if an insulin which is not an NPH, but they are cloudy, they are bad. All other insulin other than NPH, they are all clear. Only NPH is cloudy. And one more thing I will add here. When you have more than one insulin you're pulling in the syringe, clear before cloudy. So you pull the clear first and then cloudy means NPH is pulled at number 2 if there's more than one. Okay? Now comes the long acting. So they do not act quickly. They take even longer, 2 to 4 hours to work, and they peak around somewhere, I would say 4 to 10 hours, 12 hours around there, based on different products. You know, and the duration of action, the long acting is technically, I would say that they cover from 20 to 24 hours, I mean the whole day. That's why they're used only once a day. They are the baseline. And one of the most common example is your lentis. Lentis. Okay. Now the names you can kind of remember. I just put down like DGD, like degludec, which is Toshiba, then detimir, which is Levimir, and glargine, which is your lentis. So they are different type of insulins. Okay. Then they're ultra long. Ultra long, they have, if you can read here, it says glargine, for example, Toheo, it says U300. What that means in that in 1 ml, it has 300 units as compared to your regular insulin, which is U100, that has 100 units. So it has much more units in there, and it lasts longer. And another thing important to remember about these long-acting and ultra-long-acting, they actually don't put your patient at risk of hypoglycemia, you know, if they don't eat in between. Sorry, guys, give me one quick moment. I have to take this call real quick. Sorry about that, guys. It was something important. Okay, so these two drugs, which are long-acting, they don't peak. They go like, you know, for example, they start working after a few hours, and then they maintain the level pretty much the whole day. So when your insulin peaks somewhere in between, that is when your patient might be at risk of hypoglycemia if they don't eat at that time. Peak means maximum effect of that drug, which is insulin, and the maximum effect of insulin is dropping the blood glucose. So when these drugs, we don't have to worry about that part. Okay. Any question so far?
Yeah, what was that thing you said about clear over cloudy?
Yeah, I will repeat that again, but just basic. When you have two insulin, when you're mixing up, right? If they're not pre-mixed, you're mixing two type of insulin. One, you may say that that's an NPH, right? The intermediate acting, and one is regular, rapid acting, whatever it is, right? So we know that NPH, the intermediate, is the only one which looks cloudy. When you look at the vial, it's not clear. It's kind of a little cloudy. But all others, they're clear when you look at the vial. Okay, so if you have to pull both, now, I mean, obviously you have to pull one first, but which one? You always pull the clear one first. So NPH is always the second one to pull, but there is another step to follow. Remember, before you put the syringe in to pull, you push an equal amount of air, right? If you're pulling 1 ml, you gotta inject or push 1 ml air. So now, if you're pulling it from 2, so it's like, say 1 there, right? So 2, you pull the plunger up to 2 ml. Now you're going to push the air first in the NPH first, which you're going to pull at number 2, right? But air, you're going to push number 1. And then you're going to push the air into what you will be pulling first. Okay, so that you can that in the single step. Make sense? Okay. Alrighty. This just says, how the onset and when the peak is and how long it lasts. There are multiple there. It's not that useful, but I just wanted to show the different type of insulin. But you might want to use something like this. Make something like this. This is not complete, but it's a good example to develop, and this is going to help you to answer a lot of questions correctly. Okay. For example, rapid acting. If you see, it says aspart, glulicin, lispro. Now, write down the mnemonic there, AGL, for rapid acting, AGL. That should help you. Oh, aspart, glulicin, lispro. These falls under rapid acting, right? And then, okay, what are their names? Well, it says most of them ending in log, Humalog, Novolog, right? So we are developing it in a single thread that you know the relevant information, which is important in single line. Then onset, how long does it take to start working? Like 10, 15 minutes, okay. When is its max effect, the peak? It says there. How long does it last? It says there. So now put up the same thing for short acting, which are called regular as well, and regular starts with R. So these drugs will have R at the end, Humulin R, Novolin R, and then the onset of action, peak, duration. Similarly, intermediate, as we mentioned, they are the only one which are cloudy. They have N at the end. They're called NPH, and then long actings. So I want you to know these things about all these different type of insulin. How would you know which ones are under rapid acting, short acting, intermediate, long acting? By putting up these aspart, glucin, lispro, AGL, and then another one I showed previously, DGD. The topmost and the bottom are the kind of has the most ones. And if you develop that kind of mnemonic thing, that will help you to make it easy. And also know reversible. If we give you a name, then are you able to identify if it's a rapid acting, short acting, which one it is? So all you need to develop this block that will help you to answer all those questions. Any question how to develop this piece? Everybody understand? But I really wanted to stress on this, that please, please, please do not assume that you can memorize this. You may memorize it temporarily, okay? But if you don't develop it, it's just a matter of, I would say, a days, 2, 3 days, 4 days, everything will vanish. So the right approach is make your own, like something like this, which includes all that information, and keep it like concise. Don't put too much information, just like this. Just what you need to know. You just need the hints. That's all. Okay, and then try to memorize and then try to write down. See if you can recall. How much do you remember? Repeat it few times. If you are able to imprint this picture here, you're going to answer a lot of questions correctly. Okay. For example, if I ask you, okay, long acting, right? Or if I say Datimir, Glargine, or if I give you a name, Levemir lentis, what is its frequency? How many times it's given? Well, it says here duration. So 12 to 24 hours here, it's a 22 to 24 hour. That will tell you, oh, it's once a day. So this information from this table will help you to answer questions. Now, if we talk about insulin administration, there are different ways, okay? They're pre-mixed ones, right? Comes pre-mixed. Then you may need to pre-mix vials as well, which you need to pull. Then there are pens. Then insulin pumps, and there's form inhaler as well, but it's not commonly used, not that effective. Okay. One thing I want to add, and that's important, guys. So please remember that as well. Because when we're talking about diabetes, technically we're talking about high blood glucose, but there are other things which can temporarily increase patients' blood glucose, such as if your patient is taking steroids, they're taking prednisone, methylprednisolone, it's going to raise patient's blood glucose as well as blood pressure. So make sure you include that aspect, assess that. Is they're taking anything? Okay. You may need to adjust their insulin dose. For example, they're diabetic, they're on insulin, but they got sick, severe infection or inflammation, and the doctor put them on steroids. So steroids is going to increase blood glucose. So you may need to increase the dose of insulin for that period as long as they are taking steroids. Make sense? Okay. Now, if it's an insulin, whatever the method they're using, just pick up one of them. Let's say pump. Okay. Now, pump is a device. Pump is a device. It's important you educate the patient how to use it correctly. Right? They won't be able to if they don't know. Then how do you make sure the patient understood what you told them and they will be able to use it correctly at home?
Have them repeat it back to you.
Excellent. Tell them to give you a return demonstration so that you can assess if they know everything, what they should be knowing. Otherwise, you educate them again about the missing aspects and then make sure they know how to use it. Okay. Now, this is what we were talking earlier. Clear before cloudy, okay? If there's more than one, if you're pulling two, clear before cloudy. And which one is the cloudy one, guys?
ENPH.
NPH, which ends with N. They will have N at the end, okay? Humulin N, Humulin N, whatever N. What if your regular insulin is cloudy? What should you do?
Discard it and let pharmacy know.
There you go, perfect. Okay. And similarly, if NPH is not cloudy, it's clear, same thing. Okay. All right. Now this is the same thing, guys, which was on that table. Okay. So I'm just going to go over that real quick. I'm not going to spend too much time. So rapid acting. Remember, Humalog, Novolog, they're all rapid acting. Okay. AGL, remember that. Aspart, glycine, lispro. How long it takes? About 10 to 15 minutes for them to work. Know the peak and know the duration, how long they will last. So that is important. And once again, I'm just putting up here on different slide, but as long as you develop that table and memorize that, you'll be fine. Now here's the inhaler called Afrezza. It acts quickly but doesn't last long. Does not have kind of, I would say, much of a positive data to support its use. So that's why you won't see it much. Very rare. Okay, short acting. Short acting are also called your regular insulin. They end with R, humulin R, novolin R. So once again, you need to know what is the onset, means how long it takes to start working, 30 to 60 minutes. Well, when does it peak? Need to know. And how long does it last? Now, a few more things, please notice. It's extremely important, okay? One thing was, we talked previously, but let me say this. This is the short acting or your regular acting insulin is the only one which can be given as an IV. Know that. Okay. Then it applies to those patients as well who might use infusion pump at home, right? Once again, regular insulin. Well, the same thing applies if they're going to use insulin pump for this regular insulin. Well, we need to educate them how to correctly use it and ask them to give a return demonstration to make sure they will be able to use it correctly. So these are important things about it. Okay, intermediate. These are the NPH, right? Ends with N, and they are always cloudy and they're pulled at number 2, never first. Correct? Another thing important which I want you to remember about these intermediate. Do you see how it says they peak around like 4 to 8 hours? 4 to 8 hours or so? Then why it is important for these drugs? These drugs can cause hypoglycemia around the 4 to 8 hours window. Okay. I would say probably stick to about 8 hours or so. That's where its maximum effect would be. Means its ability to reduce the glucose. So patient will be at high risk of hypoglycemia. What do? Give something to eat at that time. Because, hey, it's been already 8 hours and you don't want to forget this. Okay? So that is also very important. Give a snack to your patient, something to eat. Now, as far as long acting, as the name says, long acting, they act for long. So that is why it's once a day, usually somewhere from 18 to 24 hours based on different products. 18 to 24 hours, that's how long they last. Frequency once a day. That's why they're called basal insulin. They start working and they consistently stay in like this at the same level. They don't cause peaks. Okay. I'm going to skip this. Okay. Then another ones are a combination one where they already come in a pre-mixed form, like where NPH and regular are, in different strength. Like, in one, it's 70-30 means 70% of NPH and 30% of regular, or 50-50 or 50-40, it comes in different strengths based on percentage of one or another. Okay, this is the condition which was mentioned in the video as well, diabetic ketoacidosis. Now it's a long term, let's break it. Diabetic, a condition in diabetic patients. What is that? Ketoacidosis. Because of keto means ketones. Because of ketones, what happens? Acidosis. Too much of acid means the blood becomes acidic. Okay, blood becoming too acid because of ketones in diabetic patients. That condition is called diabetic ketoacidosis. Is that clear? And what type of patients it happens? When blood sugars are really high, insulin levels are real low. And these are when patients are non-compliant. Okay, patients are non-compliant. Very unique identification aspect is their breath becomes like, it smells really like a fruit. When you enter, go close, it smells like fruit. Okay. Then respiration, kusmal, my labored breathing. Okay, labored breathing. The heart is beating fast, but hypertension. Now, what do? We need to fix the problem. So you give them IV, right? You give them IV. Now they have high blood glucose, right? Extremely high. So what you want to do? You want to move that glucose from blood to the cells. And who helps in that? Insulin. So after you give them IV fluids for hydration, you include insulin, and insulin helps shifting that from blood to the cells. And this imbalance can also cause an imbalance in electrolytes as well. So you may need to look into their electrolyte levels and see if you need to supplement any. Okay. Educate your patient about making changes in what they eat. Okay, what they eat, that is important. And also staying fit. Regular exercise is important. Now let's talk about drugs, guys. Okay. Oral diabetic drugs, when none of the lifestyle interventions and all that doesn't work, okay, or the A1C is too high, patient high risk, well, you need to intervene with these oral drugs. The first one, biguanide, that's what the class of the medication is. There's only one, metformin. Everybody knows about metformin? Heard about metformin? Metformin class is called biguanide, and there's only one in that class. Okay, that is first line. But if the patient has a high risk, well, they may introduce injectables as well. So there are different classes here. Biguanide we just talked about, then there's sulfonylurea and all the other ones, and we're going to go over them one by one. Let's go on metformin first, because it's an important, common drug in the first line, right? So first line drug, the first question comes is, how does it work? How does it reduce the blood glucose? Well, it decreases the production of glucose in the liver. It does not increase the insulin production, because any drug which will increase the production of insulin will put your patient at high risk of hypoglycemia. But this one doesn't. That's why I would say almost all patient, very rare, okay? I mean, I'm not saying it cannot happen, very rare. But normally, it doesn't put your patient at risk of hypoglycemia unless they didn't eat for the last 2 days. Okay, so make sure you know how does it work. It decrease the glucose production in the liver, also decrease the absorption of glucose intestine, also increase the sensitivity of the receptors, insulin receptor. Remember, the body or the pancreas does not produce enough insulin, or the body is not sensitive now, or mix of both. Now, what else is